depends where you are, and this is definitely a jurisdictional agent, is at least there are now 5 tyrosine kinase inhibitors available in the Western world. There's a couple more in the Far East. There's a drug in Korea. There's another one in China that are routinely being used. In addition, over the last couple of years, there's been a new drug that's now starting to go on the market, which is something called the STAMP inhibitor, which works at a different site on the BCR-ABL molecule and is now available for at least third-line treatment with patients with CML. So again, what you can use may be what's approved in your country, what's reimbursed in your country, what are the guidelines for using of that drug, but it's also other things. It may be what you are comfortable using. As some people don't want to go into a drug they're not very comfortable using as a treating physician, they opt for something else. That is potentially a problem, because sometimes it will, as a physician, you hear of a drug that you think has a bad reputation. You don't know how to work around that reputation. It may result in you leaving your patient on a drug that's less effective or has side effects rather than moving on to the next treatment. And that, I think, becomes really important. I think the hottest thing right now is what's to be used in third-line treatment. And I think that's a big issue. And there's really 3 drugs that have some approval for third line, but even what's used in third line may be based on the reason for wanting to switch from first to second to third line. For instance, if you're getting a patient who's having some tolerability issues, you may actually go from first to a second generation drug and switch to another second generation drug just because of tolerability. You don't need to get into a third line drug. If you have someone who, for instance, is developing resistance because they have a specific mutation that will allow you to use a second line drug, second generation drug. In some cases, you have a patient who's having toxicity. You may, in fact, go back. You may go from a second line drug back to imatinib for first line. So what exactly is the reason for the switch is very dependent. Let's assume, though, you've got 2 patients with general resistance and no particularly markers as to target which drug. 3 drugs that are on the market or approved are, number 1, bosutinib, which is probably the safest TKI that's out there. And there's actually a recent paper which actually showed that it can be very good in individuals who don't have specific markers or don't have specific targets for using, and when used appropriately. Now, very often what happens, and there's some studies that have gone out there, which takes the product monograph dose and have used that, even though people have experienced using a drug like bosutinib will tell you don't dose it that way, you don't use that dose, and you ramp up the dose, making it a lot safer. Getting rid of a lot of side effects, which took patient off that drug in another study. Another drug which is approved is ponatinib, which has a very bad reputation for what was out there a number of years ago in terms of vascular side effect. But there was a recent study published a year ago that shows that it remains extremely effective. And when you can start the drug at a certain dose and dose down once a response is achieved and greatly diminish the side effects. Here was also a very classic case where when the vascular side effects were reviewed by experts on that, a lot of what was claimed to be vascular effect is not. The newest drug on the market is a new drug called asciminib, which is a STAMP inhibitor. It's out there. It shows some very good efficacy in people who have not responded to other medications, in some cases, or been intolerant. It seems to have a relatively good tolerance out there. There's a randomized study which compared it to bosutinib. I'm not going to go into details on the study because I think it was a very unbalanced study in terms of how it was dosed in the patients in both arms and look at certain, but it is extremely effective. It may very well prove a benefit for people who are intolerant or resistant to other things. There's some issues around what dosing to use, which still is not resolved. For instance, T315, it's used at a dose 5 times the regular dose, which makes it profoundly expensive. They also, even some of the newer frontline studies, have changed the way it's dosing from twice a day on an empty stomach to once a day on an empty stomach. So it's not even resolved as to what is the optimal dose, but it's extremely effective. And in cases with resistant patients, it offers a really good alternative in some cases to what's out there. So those are the ones that are out there. And as I said, asciminib is the one that is rapidly moving through approval. It's approved in the States, approved in Canada for usage, approved now in Europe. They're now, at least in Canada and Europe, going through reimbursement issues and things like that. It's really good. It's good to have another alternative. There's also at the meeting, there's a couple of new drugs working through trials. One that's not targeted to 3115I is very good for many other mutations, and it seems to have very little in the way of side effects working on. Another drug, which is a Chinese drug, and some other drugs which look very effective. There's another asciminib alternative, which is starting to be used, coming up in the market, some other ones. So I think we thought for a while there that we'd hit the wall in terms of what drugs are available. But in fact, there are others that are going in a trial that may offer alternatives, both in terms of efficacy and safety compared to some of the drugs that are out there, including the ones that are hitting now.